This is Dr. Stuart Goldsmith presenting a new approach for the clinical diagnosis of melanoma. This approach has recently been endorsed by the Georgia Society of Dermatology and Dermatologic Surgery. Why we need a new approach for melanoma diagnosis is because of the relentless increase in the number of yearly deaths in this country, from approximately 5,000 deaths in 1982 to approximately 9,000 estimated deaths from melanoma in 2012. Melanoma is one of the few cancers for which the mortality rate is not decreasing in this country. There has been, though, an enormous increase in the incidence of melanoma, and there has been some success. Early diagnosis does save lives. Melanomas are being diagnosed earlier, but for a cancer that is on the skin, visible to patients and physicians, without any special test or instrument or cost, no one thinks that we are doing enough in this country to prevent deaths from melanoma. To save more lives, some lesions that are not currently being diagnosed need to be. A principle of physical diagnosis and of melanoma diagnosis is that what we see depends mainly on what we look for. So what do we look for to help recognize melanoma? The approach begins with a screening look, which has been referred to as macro screening. It's a scanning look where you're looking at big areas of the body, and it doesn't have to take long at all. Once a month, with the help of a family member, friend, or significant other if possible, examine your skin from head to toe. That means from the top of the scalp to the bottom of the feet. Many people have died from melanomas in these locations. And you're looking for any mole, spot, or bump that seems to stand out because of being dark, different, or changing. The strategy of looking for changing moles has been publicized since the 1950s as an American Cancer Society warning sign. The strategy of looking for different lesions is more recent, the so-called ugly duckling approach, and is based on the thought that melanomas would stand out in their field. What is being added is the strategy of looking for dark lesions, which as a single specific objective feature enhances the usefulness of the other features of different and changing, as well as being important in and of itself. The very name melanoma means black tumor. The ABCDE criteria form the basis of the detailed look, which is the look that one does when trying to determine if a lesion that has been identified on the screening look or a spot that is being examined for any reason needs more evaluation, particularly does it need a skin biopsy. The criteria in the approach I'm presenting are based on the ABCD criteria that were published in 1985, but with the important difference of a change in the D from the 6 millimeter diameter criterion to dark, and also in its relationship to a screening look, which is more emphasized in the approach I'm presenting. It is also worth emphasizing that all approaches are complementary and no one feature or criterion is present in every melanoma. I want to illustrate the ABCDE criteria, showing lesions both with a screening look and on close-up. First, A for asymmetry. Does any one half of a mole look different from the other half in color and or shape? This melanoma stands out with darkness and erythema. On close-up, there is striking asymmetry of both shape and pigmentation when a line is drawn in any direction, comparing one half to the other, right, left, up, down, or in any direction. There is also variation in color and darkness. B for border. Does a mole have an irregular, jagged, or blurred border? This melanoma stands out in every way in this field. The patient came in because of this lesion. But on close-up, even more, the jagged border here, irregular, in most locations, a lot of variation in color, asymmetry, dark as well. C for color. Does a mole have different colors or different shades of one color? On screening look, this lesion is dark. If one knows to look for dark, this lesion would immediately stand out. On close-up, there are many different shades of brown, also black, also erythema, also the other objective features of asymmetry and irregular border. Note for lesions where patients can't see, the history of change often is totally unknown, but the diagnosis of melanoma still can be made and should be made. D for dark. Does a mole appear dark, or does any area within a mole appear dark? If one learns to see darkness, even a melanoma this small can stand out in this field, where the only objective characteristic is really that of darkness. In these melanomas as well, the only reason that these were examined more closely is because of the criterion of darkness. Any consideration of a 6 millimeter diameter criterion would have only delayed diagnosis of these melanomas, as it would delay the diagnosis of all melanomas at the earliest stage. I had mentioned this new approach includes a change in the meaning of the D from 6 millimeter diameter to dark, with the goal of diagnosing some melanomas earlier than they are now being diagnosed. This single change is an advantage for two reasons. We are replacing a feature never present in the earliest melanomas with a feature that characterizes many early melanomas. E for evolving. Has a mole, spot, or bump evolved or changed in a way unlike any other mole, spot, or bump? This is the melanoma. This is the lesion that the patient came in for because of the way it had evolved, both growing in size and becoming more painful. On detailed look, there is a lot of variation in color. In addition to darkness, note the erythema here as well. This is a nodular melanoma that sometimes has no specific feature other than the fact that they evolve quickly and look different from any other lesion. These nodular melanomas often are more aggressive and can be fatal at an earlier point in time, and it is particularly important to try to diagnose these lesions when they are as early and small as possible. This slide shows the ABCDs of malignant melanoma on a Delasco educational poster. It was formulated before the E for evolving had been added, and I've included this for several reasons. First, to show that when other features are being illustrated, the melanomas are often, if not usually, also dark and could have been recognized because of the darkness as well, hopefully earlier than they were. Secondly, is to show this nodular growth here and here and here, as in the last patient that I had presented. Nodular growth can often occur within moles or can often occur without any recognized precursor mole. In these examples, this is dark nodular growth, and this is pinkish red nodular growth. Nodular melanomas, more often than other melanomas, are pinkish red. Finally, I wanted to illustrate how this nodular growth, which is so important to recognize early, is very apparent when much smaller than 6 millimeters. I wanted to present several examples of using this approach. On screening look, in this field of dilated blood vessels, there's a lesion here that does stand out. It's not a blood vessel and there is focal darkness, which on detailed look is very apparent and would lead you to look even more closely and see that there is really a lot of variation in color, though subtle, and asymmetry and irregular border. This is a patient that has a common scenario of a lot of crusted lesions that are not true moles. But if you're looking for the different lesion, you notice this smooth one here that is different from these others, and on close-up look has a lot of variation in color, asymmetry, dark, and this is a melanoma, but the reason it was identified is because it looked different in its field. This melanoma stands out primarily because it is so dark. The patient's daughter noticed this lesion that also is different in its field, also was new. They brought it to the attention of a family practitioner who, with the intensity of pigment in mind, made the immediate referral to me. On detailed look, there also is subtle variation in pigmentation, irregular border, asymmetry of shape. I hope you were thinking that this melanoma would be easy to recognize, because it would be, but only if someone takes the opportunity to look and understands the importance of recognizing dark, different, or changing lesions. Even on someone with many lesions, the strategy of identifying the single darkest lesion or darkest lesions can help identify the melanoma at a very early point, as this one was. On detailed look, asymmetry of shape and color, and focal darkness. So you need two looks. The first look to try to identify anything that stands out, any ugly duckling, and anything that you have noted to change, and the second look to identify the darkest lesion or lesions. This is a summary card of this approach to melanoma diagnosis. A PDF file will be available at the GSDDS website, www.georgiaderm.org. Hopefully you know more now of what to look for in melanoma diagnosis, because again, you don't find what you don't look for. So with this knowledge, please look. And secondly, if you have any concern about a lesion, do not delay in seeking evaluation. Thank you.